are funded by the Administration for Strategic Preparedness and Response within the Department of Health and Human Services. Next slide. Disclosures here, we won't read through these in great detail, but really just ensuring that we capture that this webinar is presented by the individual speakers and does not represent or reflect any official policy or position, and that our speakers have no affiliation or financial interests or relationships to disclose. Next slide. So really excited for everyone to be here today. My name is Jen Shearer. I'm the Director of Emergency Preparedness at Massachusetts General Hospital. I'm joined today by two incredibly distinguished speakers who will be talking about an incredibly important topic. And so we're joined today by Dr. Brian Flynn, who is currently serving as the Special Advisor to the Director in the Center for the Study of Traumatic Stress. He's also Adjunct Professor of Psychiatry within the Department of Psychiatry for the Uniformed Services University of Health Sciences in Bethesda, Maryland. We're also joined by Captain Jennifer Borneman, who is a captain in the U.S. Public Health Service and serves as the Disaster Behavioral Health Lead within the Administration for Strategic Preparedness and Response. And so very excited for the content that they're going to share today. So we go to the next slide. Just want to capture the high-level learning objectives for what we're hoping to capture. And so not only a discussion and ground key components of disaster behavioral health, including short-term and protracted effects, but as well as understanding and applying best practices in supporting healthcare personnel who respond to large-scale disaster incidents. And then finally, identifying the opportunities for healthcare organizations to enhance their plans that will really support improved outcomes for employees. And so with that, I'm going to turn it over to Captain Borneman, who's going to provide a few initial comments, and then we'll dive into the content for today.
Hi, all. It is such a privilege to be here with you today. I love our partners up in Region 1, and so it's really great to be with all of you. Again, my name is Jen Borneman. I am with ASPR, Administration for Strategic Preparedness and Response. I am one of the disaster behavioral health leads and a licensed clinical social worker. So you will hear my way of doing this kind of work. You'll hopefully notice a little bit of passion that I might have, and feel free to ask any questions as we move along in the chat, and we can go from there. So we'll go to next slide. So I really would like Dr. Flynn to share about the organization that he's a part of, Center for the Study of Traumatic Stress, but I guess I can help. He's a little delayed in joining us. I actually used to work with him at CSTS. And for those of you who aren't familiar, they have tremendous resources around disasters and military and veteran military families, you name it. They've got fact sheets and the like. They are actually my first go-to when an event happens for particular fact sheets. So I encourage you to, you will receive the slide deck, I believe. So I would encourage you to click on that link, bookmark it. So God forbid things should happen. That's a great place to go. And I'm sure Dr. Flynn could do a great job talking about the wheel, but that's newer since I was involved. But they really are in lockstep with Department of Defense and the Uniformed Services University in being this this wealth of knowledge around disaster and military behavioral health. Next slide. And something I can speak a little better at, we'll see, but is ASPR disaster behavioral health. And so we try to provide the subject matter expertise and education and coordination to internal and external partners, and that's federal, state, local, territorial, tribal partners around public health and medical emergency response and recovery. And so we're involved in just about any type of event, from mass violence events to tornadoes, hurricanes, flooding events, you name it. And we try to provide that connection, coordination, capacity building, concrete solutions. I didn't make this up, but there's definitely a C thing going on there. But I want to highlight the newest part of our role, and that's this disaster direct care and support. Unlike it's in the entirety of its history, we hadn't been involved in the actual operational side of providing direct clinical care after an event. And so this really kicked off in Maui. So very recently, last August, we provided, through United States Public Health Service officers, we provided direct behavioral health care in support of our local and state partners in the aftermath of the Maui wildfires. And actually, so of course, we can't do anything easy, right? Our first time doing this is the largest ever response in the behavioral health setting. And so we actually provided that care from, August through January, that direct clinical care. And we also provide, but our main role is really around consultation and really supporting our partners. So like those of you either with local hospital systems or with state and local governments, we really want to support you all as you prepare, deal with, and hopefully recover and then mitigate other future events. Next slide. So looking at disaster behavioral health, we focus on the survivors and the responders in terms of, the populations. Force health protection is essential, and we'll be talking more about that throughout the presentation. We pay particular attention to those with pre-existing conditions. And we spend time around behavioral healthcare infrastructure. We know that it's challenged everywhere in steady state blue sky situations. So it's something that we really want to work with our local partners on in terms of what we can do from the federal level to expand or support. Of course, the individual and community resilience and recovery, that is so very important. I make a point, while we tend to work on a systems level, to really have interactions on the individual level, because there's nothing like looking in the eyes of a disaster survivor and letting them know you're there for them. And it's what fuels my work and the way I do what I do. We also get very involved in risk communication, leadership messaging, and the like. Through many responses, I don't know if this was like a formal role, but it ends up being always part of what we do, and helping leaders best communicate either to their organizations or leaders out broadcasting out into the communities and the like. So it's a big piece. Next slide. So in terms of the psychosocial consequences of disasters, just taking a look at the, really what we're looking, which also includes pandemics, which, obviously it's first and foremost, and it has been on all of our minds for the past 40 years. And then the human generated disasters, both intentional and non-intentional. On the intentional side, the mass violence and terrorism piece, and each bubble, if you will, it brings its own uniqueness to our approach in terms of the way we do what we do, and it brings different stressors, different reactions. And it's just the way we look at our work. Next slide, please. Okay, so there's a lot going on this slide. but I want you all to just sort of sit with it for a minute. And so most of what happens to a population after a disaster is behavioral and associated responses. It's not PTSD. Like we cannot pathologize within our role in disaster behavioral health, right? That is something I hold paramount in the work that we do. It's also important to note that most of the symptoms go away on their own. We facilitate, we focus on facilitating well-being and resilience with the goal of lowering any chances, or not chances, but in the population, trying to support them so that they don't develop psychiatric illness or any lifelong detrimental reactions to the event. But even so, those numbers are very, very small. It doesn't take away from the intensity that folks experience the event, the immediate trauma, and then longer term trauma from the event. And so we try in disaster behavioral health to really connect with folks and support them in that immediate time frame. An interesting point is the most common emergency department complaint after 9/11 was actually insomnia, not PTSD. So you can see how these reactions develop in different ways in terms of changes in sleep patterns, irritability, increased alcohol intake, things like that, right? And yeah, I think that's what I want to cover in that slide. Next slide, please. Okay, so here's a bit of a snapshot in terms of how we look at disaster behavioral health versus traditional mental health. Well, those of us providing this work, we're all licensed clinical providers, although there's a lot of opportunity for peer-to-peer. So that's a whole nother topic. But the way we do disaster behavioral health is very different than traditional clinical treatment. We tend to look more at the population, which of course is comprised of individuals, and that can never be lost, right? That is something that we always pay close attention to, that we might be looking at the population as a whole, but we take into account every single individual that comprises that population. We focus on individual and community resilience, not pathology, like I was just talking about. We work with leaders and others in a consultative role around leadership and communication. Whereas traditional mental health, not as much. And a big difference in disaster behavioral health is we go where the people that we're serving are. We go to those impacted communities. We go to the shelters, to the schools, wherever they are. I tell you, I tend to have some of my most meaningful interactions at a grocery store after events. It's people are doing, like, trying to get back into a routine. They're doing something that's, something that they're accustomed to doing, but everything has changed in a bit, and the uniform is kind of a giveaway, and hopefully they like my smile, and so they feel like they can talk to me, because it happens all the time. And so when we're doing this work, there's no real off time, because we are there short term. Even in recovery missions, we're there for the shorter term, and so we want to support every chance we get, and that's often wherever we are, which is hopefully where they are. Next slide. So who are we talking about? You can see here, you know, who the folks are that we focus on. But we focus on these groups in the hopes of not completely disrupting the behavioral healthcare delivery system. That's a big piece, right? Because it's not like heart attacks don't happen in disasters, or strokes don't happen, or cut legs. In fact, all of those rise, right? The incidences of those rise. And so we really want to provide that support so that the healthcare system can continue on, as challenging as it is. And, you know, one key and one area that I've seen work so well is crisis response teams. So if you happen to have them in your community, that is awesome. If you don't, love to talk more about it, because these crisis response teams, they're, you know, they're set up already. They're staffed. You know, they have their schedules and their systems and their equipment, right? And so I just find them absolutely key when it comes to disasters, where they can go out and, you know, I see it as a bit of a triage system, right? Checking in with survivors, immediately assess their needs, and then so we can send those who are, you know, severely mentally ill, or you know, suffering from substance use disorders or any concurrent illnesses, where, you know, we can get them exactly where they need to be, and we can support the masses, if you will, as they're dealing with a traumatic event. I mean, not to take away from the absolute trauma that they're experiencing, but it's important for us to really support the healthcare system as we do our work.
And Captain Norman, I'm going to introduce you, if I'm interrupt you, excuse me, if I may. I've got Dr. Flynn finally with my audio here. So if that's okay, I'll just ask him to speak and confirm that you can hear him. But I apologize certainly to you and to everyone for the technical difficulties in having him join.
If I may, as we transition, this is what I wanted to say earlier. I have to say that so Dr. Brian Flynn is my co-presenter, and I'm grateful that he's here. I've tried to make it by without him, but I have to say that he is also a mentor to me. He's like a godfather to me, and a colleague and a friend. And he is retiring, and I asked him to join me in this webinar because his roots are in Region 1. This is where he got started. And I am incredibly proud to know him, and to certainly present with him. And so now I will turn it over to you, Dr. Flynn. If you are tracking, we're on the psychological first aid slide.
Okay, well, I am so sorry that we're having all these technical problems. Yeah, I've really been looking forward to this. As Jen said, I have a special connection with New England. I worked at the NIMH regional office in Boston, serving New England, worked in the government center, and that was where I first had my initial disaster experience during the blizzard of '78. And yes, I'm that old. That's why I'm about to retire at this point. But I got my baptism in disaster mental health, and it became a passion in my career. And it's just wonderful to be doing something, or trying to do something, for New England, where a lot of my heart is, and it's kind of a nice way to bookend this toward the end of my career. I guess you've gone through the other slides at this point, and you're going on.
Yes. But next slide, please. The psychological first aid. That's where we are.
Okay, let me find PFA again. Is that what slide? I'm sorry. This is
14. And I can just start in terms of psychological first aid. This is something that I use in my day-to-day, not even just in disaster behavioral health, but it is the foundational way we do our work in terms of, as listed in this box, providing a sense of safety, calming, sense of self and community efficacy, connectedness, and hope. And these aspects are essential in this work that we do. And I can tell you, I use this every single day in all of the work that I do. Are you ready, sir?
Jen, let me just pick up there, and I'll just mention something on this, then I can move on to the next slide. But I found in my career there's probably half dozen articles that really are seminal articles that I wind up referring to year after year. And I would highly recommend this article in Psychiatry, which is really the first time that the grounding of PFA was established, when they did a meta-analysis of early intervention activities and found that these 5 essential elements came up as being efficacious for early and mid-stage trauma. So I would encourage you to take a look at that and use that as understanding the basis of PFA today. Would you like me to go on to the stress continuum at this point?
Yes, next slide.
Okay, thanks. I also thought it might be helpful for you to see a slide that has been produced by the Department of Defense that talks about the kinds of experiences that combat troops may have. And we found that this has high applicability with other kinds of traumas. And it talks about a continuum from being okay to needing some very serious professional help. And without going into the details, it discusses the kinds of things that you might see when somebody is doing well, when they're beginning to find some reaction to stress, and then becoming more seriously impaired to the point where somebody may need evaluation and definitive treatment. And it tracks through the different things that one might look for. And also on the bottom, it talks about who might be most helpful in those situations, from peer support to leadership and organizational support to when someone needs the armamentarium of a behavioral health professional. One of the things I might mention to you is that this has been made into a pocket card for DoD personnel who've been leaders who've carried this around just to remind themselves of when people may need different help in different stages. So one of the nice things about this and all of the materials that you'll find in the link to the Center for Studies of Traumatic Stress is this is all in the public domain. So if you guys want to use that and adapt it in some ways for your facilities and situations, you can do that. So next to you, Jen.
So you could keep going. Sorry. Keep going. That's all right. Thank you. So instilling hope, and this is a delicate balance, right? You never want to be just appear like you're walking through the world with rose-colored glasses, like nothing is going on. These challenges that folks are experiencing, they are very real, and people experience them in a very personal way. And there's often a great deal of pain and grief. That said, it is important to instill that sense of hope, because things will get better. They will be different. But that sense of hope must be instilled in these organizations or communities or families, in whichever you exist. And so you never want to undermine the personal and community impacts of the disaster, but it is also very important to normalize and reassure. And so that whether you're a formal leader or not, this is a piece that I think people get pretty anxious about. Like, how do I do this right? How do I get this right? And that is what you do. It's about acknowledging where people are, right? That's so very important. But also instilling that sense of hope in a real, genuine way. Next slide.
Thanks, Jen. I wanted to just say a couple of words about leadership. I've had a lot of field experience with disasters, and I've learned a couple of things in the process. One of those is the importance of leadership. While counseling services, I think, are important and ought to be provided, if you can't have everything, give me good leadership and good communication, and you've got a couple of the Lone Ranger's silver bullets. So I'm going to make a couple of comments about leadership. One, it's important. It can make or break a response. I think it can be studied. And there are different kinds of leadership that might be necessary and appropriate for different kinds of responsibilities and different phases in the life cycle of an event. I believe strongly that leadership can be developed. And just as an aside, one of my biases is that we really don't pay enough attention to successorship of leaders. I've seen great things happen, programs built, systems developed, only to have them fall flat after leadership retires or dies or goes to another position. So we really need to think through successorship, and we don't do that very well. Next slide, please. This is what I've referred to as the propeller diagram. And again, I just want to graphically kind of show the centrality of leadership. This came from a chapter that I did with Fred Lane a few years ago on corporate and organizational response to disasters. And if you look at what happens when crisis happens, the members of the organization are impacted, their families are, the continuity of operation for the organization is impacted. Hopefully there's some human continuity preparation. There are factors like the organizational culture that are around that, and communities and families, stakeholders, board of directors, the people who rely on the organization. Where they intersect is in leadership. And again, I've just hopefully it's a helpful way of just conceiving this centrality of leadership. Next slide, please. One of my favorite writers in this area of leadership in crisis is Lenny Marcos from Harvard, and he has done a meta-analysis of crisis leadership practices, and again, the citation is there, but I found his conceptualization very helpful, that basically we need to think about leadership in the person, that there are lots of different personal characteristics and attributes that make a difference in terms of leadership. There's situational factors. That means that situations in a disaster and emergency change constantly and require flexibility and adaptability for leadership. There's leadership within the silo, meaning supporting people down the organizational chart from where a leader might sit, and also the importance of leading up the organizational chart, taking care of supervisors and bosses, and dealing with politics also, and then leading across the silos to promote coordination and cross leadership. Next slide. There's lots of different kinds of leadership. I thought I'd just briefly mention grief leadership and refer you again. Our website at the Center for Studies of Traumatic Stress has a lot of information on this. The concept of grief leadership was really initially talked about by the Defense Department following the crash of a Gander in Gander, Newfoundland, in 1985, where there was a routine military flight carrying soldiers back home from Europe. It crashed on takeoff and killed 248 people on board. And Walter Reed and Muses were asked to go to Fort Campbell, where they were destined, and Dover, where remains are processed, to work with the people who worked with the remains and with their families, and develop this concept of the importance of leading in a grief situation. Next slide, please. Again, I'm not going to go into any detail, but there are several elements of grief leadership that are described here, where there are lots of more information on the detail of that if you have an interest in that on our website. Next slide, please. Okay, again, beginning with communications. Jen, next to you.
Sure. So on the right of your screen, you will see an example of one of the fact sheets that the center creates, and they are really outstanding and brief and to the point for leaders. And you can see here, you know, being open and honest and calm and clear, and those can be very difficult in a crisis. Being visible, you know, I worked one event where the leader completely left, like for good. And the impact on the other leaders within that organization and how they were going to get through this event and then help get their community through the event was very, very challenging. And so, you know, these may seem very simple, but they are so vital to the ultimate recovery of these of your community, agency, organization, what have you. Being present, providing accurate and timely information is, you know, we'll talk a little bit more about that, but, you know, saying what you know. Don't worry about saying what you don't know. There tends to be a lot of stress around that. If you don't know, you don't have to communicate it. You don't know. But if you do know, how do we communicate this in an accurate way? And, you know, encourage working together. We're all in this together type mindset goes a long way after an event.
Just add before Jen moves on that this fact sheet is an example of many, many fact sheets that are on the website for the Center for Studies of Traumatic Stress. We've made a point of, we have hundreds of these literally that are 1 or 2 page usable informations on the topics, and all this is in the public domain, and you can take that and adapt it with our blessing for the situations and organizations that may be appropriate to you. So thanks for letting me just jump in, Jen.
No, of course, this is your organization. You didn't get to introduce CSTS in the beginning, so absolutely. But yeah, it is a go-to, and you know, I think we talked about that. So next slide. Yeah, and I think this is really truly important, and I hope each and every one of you will take this with you, in that communication is a behavioral health intervention. It absolutely is. Any event, if any of you have worked an event or been in a chaotic situation, that is what everyone is seeking, information. I know after Katrina, you know, my role ended up being mitigating all of the messages that were being shared. Oh, well, my brother said this, or my cousin said this. There was so much misinformation out there, and folks were just starving for actual real information they could hold on to. And it's important to recognize that if you're a leader or a person of influence communicating in an event, that can impact behavioral choices, like, should I stay or should I go, or should I notify someone else, or, it can very much impact behaviors. And it is true that the more credible information that is able to be out there, the more likelihood of lives being saved. I mean, think about it when it comes to hurricanes, or like we have warnings for those. Not all events, but hurricanes we do. And we need to understand that not everyone communicates the same way. And so as a leader or as a person of influence, how do we make sure that everyone understands the messages that we're sending to increase their safety and security? And also, it really helps with recovery as well. Like you'll often see, some of the events I've worked, like Umpqua Community College shooting, Umpqua Strong bracelets, and everyone wears that, and that's a form of communication, and that is it's people can get around that. And you see real success when folks are able to successfully do that. Next slide. And sorry, we're kind of harping on this, but as we said, this is a behavioral health intervention, and it is so very important because you want to promote that healthy behavior. You want to promote the healing and hope within your organization. As we've talked about, folks are desperate for information, for guidance, for direction. So as leaders, you must be prepared to provide that. And look, not everyone is great in a crisis and whatnot, and that's fine. But knowing who you can tap into, or who you can tap on your staff or in your community to help deliver these messages, is just as important, right? I'm not saying each and every one of you has to do all of these things, but you got to identify people that can, right? It's about being realistic and managing expectations, and that's of yourself, right? But also others. Crisis brings out the best and the worst in folks, right? And so setting your expectations in a manageable place. And it's important to maintain political support, and that, we got this, right? Next slide. So as we've been talking about, timely, accurate, clear information is absolute in relieving distress. Normalizing what people are experiencing, which sadness, fear, sense of loss, all of that in and of itself contributes to providing a sense of calm and connection. Just like we were talking about, remember the psychological first aid principles, right? Calm, connection. And this is how you can provide that. And I'm just going to reiterate again, we're all in this together, because it works. It works. Next slide.
Yeah, we wanted to spend just a couple of minutes talking about workers and responders and the stress that those of us who are in this work, or either by design or by chance, find ourselves in this. And even Superman, is, according to this cartoon, needs some help with stress sometimes too. And when I've done, I know a number of you are with hospitals in the New England area, and the consultation that I've done with hospitals on the topic of disaster behavioral health prevention and response, I've often I found it helpful to think about 3 roles that hospitals play, and it's actually true of many kind of healthcare organizations. First is patient care, obviously. The other is as a community partner, and the third is the workplace. So a huge part of how a hospital or any other healthcare organization or people working in disaster response have to be very interested and concerned about is preserving the behavioral health of the workforce. So next slide. What does this mean? For me, it doesn't mean just having an EAP or giving just kind of light voice to this. It means, first of all, promoting a caring organizational culture. Most people understand whether they work for an organization that cares for them or not, frankly, and unfortunately some don't. So having a caring, positive, caring organizational culture is important. Preparing people for what they do is important. Now, sometimes in disasters, people wind up doing things they've never done and aren't prepared to do. But to the extent to which we can, it's good to actually prepare people and select people to do what they're being asked to do and match these folks with skills, temperament, and availability for the kinds of things they may be asked to do. I think it's a good idea to promote stress management as a job skill. In our professions, we often get certifications and in-service training on lots of different things. I think it's good to do that for stress management also. And also, I think looking at personnel policies and standard operating procedures is important. For me, it's almost a Rorschach looking at an organization to judge the organizational culture. If you look at personnel policies, you can tell a lot about how an organization thinks about the people who work in the organization. And I seldom think that one size fits all fits most organizations. Next slide. It's also important, I think, to take a look at this throughout the life cycle of events. Before an event happens, preparing and practicing, and we talk about how important this is commonly, but we also don't very often acknowledge how difficult some of those, how difficult it is to prepare, the psychological aspects of that, to think about bad things happening in our own organization, our own families. Having preparedness exposes us to anticipating things that are pretty stressful. Having activities planned and strategies for what happens during an event, monitoring self, others, and the environment, having things like buddy systems, having communication plans, and encouraging folks to seek help if they need it, and then thinking about after an event, as it winds down or when it's over, appreciating the complexity of getting back to home and work and normal practice, and helping develop positive strategies that can help prevent things in the future. Next slide, Jen.
So there's a lot of words on this slide, so I'll let you guys digest it when you're able to take a look at the slides on your own. But just there's more of a continuum in the way we look at this, from moral discomfort to distress to then moral injury. I know many of you are probably familiar with moral injury, but this can be an area where many of us, the helpers, right, where we can actually find the most amount of distress. When we see people who aren't working as a team, or maybe creating a sense of distress, or working sort of against the tide, if you will, the tide of recovery, and we're in this together, it can really impact our work, and it can honestly impact our belief in the system and our belief in humanity. And this is something of particular concern, and I encourage each of you to take a look at this, sit with this. I know for me, it's been particularly challenging in this work. When you see these events, and it can negatively impact you and your well-being. And so I encourage you to get to know your boundaries, where you are, and know that this is very real, and it's something that can very much impact you. And I'm going to go to the next slide, though, in the interest of time. So these are our key takeaways from our brief time with you, that behavioral health is an essential part of health. I probably don't need to say this to this community, but it can't be overstated, both from an individual perspective, as a collective, and of course, as systematically. Good fortune favors the prepared. You know, we've talked about a lot today, but I encourage you to sit with yourself and do a bit of a self-assessment, where your strengths are, where your weaknesses are, or challenges, I should say, are in terms of this kind of work, so that when something happens, you're ready. Doesn't mean you're not going to be stressed, but you're going to be ready. As we've been talking about, disaster behavioral health is really more about that health and resilience. We really don't get into the pathology or of mental health in this work. Help is always available to you as you prepare, respond, and recover. At ASPR Disaster Behavioral Health, you can always reach out to us, and we can assist any way we can. Also, the resources that Dr. Flynn has mentioned with the Center for the Study of Traumatic Stress, as I mentioned in the beginning, that is my first go-to when an event happens. And that's the information I proliferate. Know your limits, know your boundaries, like I was talking about, that bit of that self-assessment. Some folks have a harder time with mass violence events, you know, man-made events that just should not happen, right? So know like what your triggers might be. And bottom line, take care of each other, please. You know, we're what we have. The peer-to-peer piece is so very important. And paying attention, listening, being present with each other. And we can get through anything if we have that kind of attitude. Next slide. So we just have some resources for you all. Dr. Flynn has a, next slide, sorry.
Thanks. Just a very quick mention, since I want to make sure we have some time for discussion. The first resource is American Psychiatric Association free 8-hour course that was developed by 2 of my colleagues at the center, and it's extraordinary. I've gone through it. Many people have, and it's gotten rave reviews. So it's continuing education is available for a number of the guilds in there, and I'd highly recommend it. Next slide.
Thank you. And NACHO and ASPR have put together a principles of psychological first aid bit of a training for leaders and teams. We encourage you to take a look at that. Again, it's free. Next slide. And this behavioral health PPE, I encourage you to look at this. Hopefully you guys are familiar with ASPR Tracie, TRACIE. If not, please Google it. And there's a wealth of information and resources in ASPR Tracie, including this behavioral health PPE, which can be very helpful as we, again, figure out where our points, our triggers might be, and also providing an extra sense of safety when we head out for the work that we do. Next slide. That's just a rapid triage exercise we've used on events. There's not a lot of literature there. So just being very honest, but it's something you could take a look at. We did use that in Lewiston, Maine as an example. Next slide. All right, Jen, back to you.
Beautiful. First and foremost, Captain Borneman, Dr. Flynn, thank you so much. Just the wealth of knowledge represented within this slide deck and across your expertise is immense. And I anticipate, similar to many others, I was furiously taking notes as well on things as we think about taking this back to our local institutions. So while folks take a moment to add any questions into the chat, just one comment, because we saw this question come through a few times. We will be sharing the slides after this, which includes hyperlinks to all of the fantastic resources that were referenced. So make sure to share that. One question, though, that I have for the both of you, really reflecting on all of the information that was shared is, I think Captain Borneman, as you had mentioned, the importance of meeting people where they're at after an event. And Dr. Flynn, this notion of really rejecting this one-size-fits-all approach, which I think is really essential. One thing I'd love to hear from your expertise is, could you provide an example of 2 of how you've implemented multimodal strategies to sort of get at that? Again, recognizing every disaster event is going to look different, but Captain Borneman, it was resonating the thought of just even being in a grocery store, right, where people commonly are at and what that means. So I'd love to hear if you have even just a couple of examples of how we can begin to conceptualize what implementation of these types of things may look like. So Captain Boardman, I might start with you and then
Oh, me?
Dr. Flynn.
Okay.
I'll start with you first.
Well, I'd like to defer to Dr. Flynn just since he didn't have as much time, if you don't mind, Jen.
Absolutely. Dr. Flynn.
I guess a couple of events really come to mind that were particularly powerful for me. One was the disaster that was the most powerful for me in my career was the Oklahoma City bombing, and that wasn't the worst, but it was the most powerful because it also combined an absolute tragedy, one that killed children, adults, injured lots of people, and it was horrific. I worked there quite a bit after that, but it provided a lot of unique characteristics that we hadn't seen before, and certainly I hadn't seen before, and that was the issue of involvement with the criminal justice system and what people's experience with that was, what their anticipation was, what their expectations were. One of the unique adaptations that was very creative was the memorial that took place there, and it was problematic. It was a challenge for that community. What do they memorialize? Did they want to make it all negative? Did they want to also recognize the people that came and helped? So the complexity of memorialization was important. As I said, the role of the criminal justice system was important. That's certainly one that comes to mind.
And for me, you know, as we know, every disaster or crisis is unique, right? If you've experienced one, you've experienced one. But I know for me, the Umpqua Community College shooting in Roseburg, Oregon was very challenging on many levels. And that was, a small town was shattered. A small peaceful, if you've ever been to that part of the country, I had never been, but in Roseburg, Oregon, it is just gorgeous. And you could just see what happened that day. Like just the sense of innocence and community was just shattered. And there were many different levels to the work because this was a community college in a small town. So it was kind of a focal point of a community, right? And so it was working with the leaders, making sure they were okay. A lot of time spent on that. So then that they could reach out to staff, and then they could reach out to students, and then the community members as a whole, and memorialization and all of that. Then there was another threat that came in, and coping with that. So there's often many different aspects to an event. And so that's why it's important to really be clear on yourself and what your trigger points are, what your boundaries are. Really knowing that within yourself, that's like my one big piece for everybody. Know that, and then you can pretty much do anything within that, right? And if you know your limitations, you can tap into others who have that capability, and you can have a stronger response to an event. And I know there's a question, I know we're almost at time, around crisis response teams. I don't know if Dr. Flynn wants to chime in at all, but really these are state and community locality run. For the most part, I know they will have to be under somebody who's licensed in a certain capacity, but I'm not certain all the providers. There's a lot more out there with peer-to-peer type support, but it will be under someone who is licensed. I'd encourage you within your state, start with good old Google and see what might pop up. But also, if you have any connections with your state or local government, ask these questions. And I'd be happy to chat more. Our information is included in the slide deck. And so please feel free to reach out for more.
Thank you so much,
I
Captain
would just
Borneman.
reinforce that, disaster response is becoming much more formalized, and that's a good thing in all aspects of it, not just behavioral health, but it is more formalized. I know that there are activities in New England that helped establish and train some teams in New Hampshire and Connecticut years ago, so I'm assuming those are still there. But having something that's organized and folks that are trained and who thought through a lot of the issues that we've talked about as a team is far superior to having large scale simultaneous response. And disaster response in general, emergency management, they talk about the SUV crisis, spontaneous, uninvited volunteer. And while in many cases volunteer services are great, it's really not the thing that a response ought to hang its hat on. Over.
Thank you, Dr. Flynn. That's incredibly helpful. And Captain Borneman, especially as we think about, I think the overlying comments made today about how do we think about this both as individuals, but then leveraging all of these resources that may exist, such as identifying those crisis response teams for our local sites. And so I know we're closing in on time. And so I really want to extend my sincere gratitude and thank you to our two presenters today and everyone's patience as I know we were working through some technical difficulties. In the final 30 seconds, I may just ask Captain Borneman, any parting thoughts from your perspective for the group, and then Dr. Flynn, just the 10 seconds, I'd say.
Thank you for all you do. Get to know yourself better, get to know yourself, how you might respond after in a crisis, and use the resources that we have shared. Thanks.
Thank you. And Dr. Flynn?
Thank you. Again, as I said, I'm so sorry that I had such problems getting on this conference. I really appreciate being included in it. A big part of my heart is in your region, and it's such a nice thing for me to have had my first disaster experience there, and one of my last disaster presentations there prior to my retirement. I think if you get involved with this, you, like I, will find it enormously rewarding. You will find that disaster mental health is actually a whole lot more about mental health than it is about mental illness. It involves rediscovering community mental health, and we owe it to ourselves and our communities and our families and our colleagues to take preparation and response seriously. So again, thank you so much for the opportunity to be with you.
Thank you, everyone. Fantastic resources shared today. We will post the webinar in short order to ensure that everyone has access as well as sharing the slides. Appreciate everyone's time today and hope everyone has a great day.